This is Dr. Lyle Jones, Editor-in-Chief of Continuum, the premier topic-based neurology clinical review and CME journal from the American Academy of Neurology. Thank you for joining us on Continuum Audio, which features conversations with Continuum's guest editors and authors who are the leading experts in their fields. Subscribers to the Continuum Journal can read the full article or listen to verbatim recordings of the article and have access to exclusive interviews not featured on the podcast. Please visit the link in the episode notes for more information on the article, subscribing to the journal, and how to get CME.
This is Dr. Gordon Smith. Today, I've got the great pleasure of interviewing Dr. Angelina Polsinelli about her article on care partner burden and support services and dementia. This article appears in the December 2024 Continuum issue, which is on dementia. Ange, welcome to the podcast, and maybe you can begin by just introducing yourself to our audience.
Yeah, well, thank you for having me. I'm very excited to be here. I'm Ange Polsinelli. I'm a neuropsychologist at Indiana University School of Medicine, where I work in the Department of Neurology. I also work with the longitudinal early onset Alzheimer's disease study that's led by Liana Apostolova. And I also do some work with the Outreach, Recruitment, and Engagement Core of the Indiana Alzheimer's Disease Research Center. This topic that we're going to talk about today is extremely near and dear to my heart.
Well, thanks for joining me. And of course, IU is a powerhouse for Alzheimer's and basketball in that order. So we're really excited to have you. I'd like to get right into it. I'll emphasize, we were chatting a little bit about this, Ange, right before we started recording, that your topic today is so important for all of us. And I think, this is a podcast that not only neurologists listen to, but students and I think increasingly members of the lay public. And this conversation is going to be very important for neurologists and our neurology learners. But I lost my grandmother to Alzheimer's disease. I lost my uncle just in the last week. So this touches all of us. So I'm really excited. And with that in mind, I wanted to begin with a statistic that you can correct me if I misunderstood it, but it really blew my mind. And that is, across the world, as I understand it, care partners provide 133 billion hours of care for people living with dementia yearly, which is pretty staggering. But what's really amazing is that by 2030, that number is expected to go to 1.4 trillion hours, which I couldn't wrap my mind around it. So I figured I'd try and determine how many years of person work is that. And if my math is right, that's almost 160 million person years of work caring for people with dementia yearly across the world. One, are those numbers right? Did I get it right? And then, assuming so, can you put a human face or experience to these numbers?
Yeah, unfortunately, those numbers are correct. And with our increasing aging population across the world, that's why you're getting that, exponential increase in care partner hours, compounded by the fact that the majority of the caregiving that happens is not done by doctors, physicians, but it's done by these informal care partners, these family members, these friends, these siblings, children who are providing these really important services. And unfortunately, not being trained to do this, to doing it largely on their own in a lot of respect. But again, these are people who are loved ones of the person living with dementia, a variety of kinships, as I mentioned, siblings, children, spouses, friends, and all sorts of age ranges as well. A large majority of them being spouses, and then the second largest majority being children. So kind of a sandwich generation of people who are caring for parents with Alzheimer's or dementia, and then caring for children as well.
Yeah, I was actually struck by the statistic that a quarter of caregivers are so-called sandwich caregivers. In other words, they're taking care of a parent and a child. But listen to what you said, but just to call it out, is two-thirds of care partners are women, which is a striking statistic.
Absolutely. Yeah. Women are not only more likely to have dementia, but they are also more likely to be the care partners of somebody who has dementia. And so the research shows, too, that if you're a care partner, you're at higher risk of developing dementia yourself. So there's a lot of risk for women when it comes to dementia, development of dementia, but also the burden and the majority of care needs that are supported by women as well.
Right. And there's a lot to unpack in that observation, and maybe we can come back to that. But I wonder if you might talk to us a little bit about the risk of dementia in women caregivers. That's really striking. Is there any thought regarding mechanism for that? Why is that the case? Is it a shared risk factor? Is it cause and effect? What's the story?
So this is kind of a dissociable or different kind of two aspects to this question. There's the fact that women are at higher risk for developing dementia in general. I think the research is still sort of out about why exactly that is. It's not just that women are at higher risk or more likely to develop dementia because they're living longer than men, but there's probably some hormonal aspects of their higher risk factor for dementia. But then the other aspect of it too is that as caregivers are at higher risk of developing dementia. And because caregivers tend to be women, that increases or compounds the risk for women as well. We know with caregiving, particularly with someone who's living with dementia, there's more risk of developing things like depression, high stress, health problems, psychological distress, and all of these things increase somebody's risk for developing dementia as well.
So I wonder if you might talk a little more, Ange, about what you mean by burden. I think we have in our mind what that is, but in reading your article, there's a lot more to it than may meet the eye.
Yeah, it is a more complicated, I guess, topic or terminology that's gone through several iterations over the course of doing research into burden. But if we think about burden, it's really a kind of a combination of both objective experiences and subjective experiences. And these objective, subjective experiences fall into the categories of physical burden, emotional burden, psychological burden. So there's a lot of different areas of life in which someone can experience burden. But really, it's a combination of factors of both the objective experience, lived experience, and the person's perception of that experience or what they're dealing with. I should also mention that it appears to be more of that subjective experience or that perception that people have of their objective experience of stressors or burden that really does determine the person's response to that, of whether they actually perceive their lived experience as being burdensome.
One of the things I found really interesting was the societal and cultural context surrounding this, that there are different cultural expectations and societal dynamics, both in the nature of the burden care partners may feel and how they're viewed. I wonder if you could talk about that. I think it's something that it would seem all of us need to be attuned to as we're working with our patients and their families.
Yeah, this is a topic we could talk for a very long time on. I will try not to provide too much of or too lengthy of a response, but what we know now is basically our models of stress and burden that we have typically used or historically used do not incorporate a lot of factors of cultural identity, of social and structural determinants of health factors. And so what we understand now is that stress and the way that people perceive burden is influenced by so many other factors than just kind of an experience and a perception, because that perception is influenced by so many factors, including, as you mentioned, cultural factors that include how society's familial expectations for us, cultural expectations for us, as well as what our resources are that are determined by, again, structural and social determinants of health, what our community resources are. There are just a lot of different factors that go into how somebody perceives their ability to cope with, again, this kind of life-altering diagnosis that their loved one has received, and them being the person who is caring for them through that.
Your article actually goes through in some detail the types of burdens and what drives the burden, and that changes over time. And so I wonder if maybe you can talk a little bit about what the specific natures of the burden are from the caregiver perspective. I mean, what sort of tasks there are. You know, from the many of us who take care of patients, we still don't know unless we've been in the room or in the home watching this happen. So maybe you can describe that for those of our listeners who maybe haven't lived through this.
Yeah, absolutely. I will say up front that the caregiving experience is going to be different for every single person. And again, kind of dependent on some of those factors that I mentioned before. So it's going to look different for most people. It's also going to look different through the dementia journeys. The experiences and the requirements earlier on in dementia are going to be vastly different than what occurs later on when dementia is in the more late stage, moderate, or severe stages of the disease. Those care responsibilities absolutely change over the spectrum of that time as well. We know that early on the stage of disease, primary care partner might be spending 40 plus hours a day. So a full-time, or not a day, I'm sorry, a week. So a full-time job carrying it. But that number increases up to 150 or so hours per week once the person is more advanced in their disease. So I say that because the number of hours, I think, putting that into perspective of somebody having a full-time, multiple full-time jobs, basically providing care, I think is really important. But the responsibilities of the care partner are going to range from everything from just helping the person early on in terms of managing finances or managing them, making sure they're reminding them to take their medications, scheduling their medical appointments for them, maybe taking over all of the driving to get them to their appointments or to get them to family outings and things like that. They're going to be the ones that's going to be the most responsible for reminding people to do something to eat, to maybe stay on track for a recipe or something that they are making. So kind of being the eyes and ears for this person right away, basically right at the beginning, even early stages. And then that progresses over time to the person who is caregiving, who is doing potentially everything for this person. So that means helping them use the restroom when they need to, helping them shower. So there's a physical component to the caregiving, as well as that sort of what we call instrumental support in terms of organizing medical appointments and things like that. They're just basically doing it all for that person.
So what about a busy clinician who has half an hour to see a dementia patient follow up? Kind of hard. But then these days, we've got, these new therapies to think about as well. What advice do you have to neurologists and other professionals caring for patients?
Yeah, and I think neurologists, we all have limited time, and I know neurology in particular, is like primary care, has even more constrained time. I think one of the biggest things that neurologists can do is really check in with the care partner. So take a moment to check in with the care partner who's there with the person with dementia to see how are they doing. You're looking for signs of burden or stress. So things like physical complaints like headaches or stomach ache, mentioning feeling burnt out or overwhelmed, maybe feeling depressed or something like that. There's also some short kind of questionnaires that you could give care partners prior to an appointment that they could fill out. You could kind of get a sense of where is this person at this point, and then help connect them potentially to some resources that might be available. And I would refer people to that article that has a list of resources in there that you could just basically print out and give to somebody.
Yeah, I was going to make the same point, Ange. Your article is a treasure trove of information. And, I keep all of these on file, as you might imagine, but I'm keeping it in hand for future use. One of the things you talk about that really hit home for me, among many, is the idea of self-care. And I think sometimes the best care partners are susceptible to burnout because they're so dedicated. You made the airplane oxygen mask metaphor, which I love. So maybe you can talk about what airplane oxygen masks have to do with dementia care and what advice you have for us in helping our patients' care partners take care of themselves.
Yeah, absolutely. Self-care is the number one thing I tell care partners to do. It's also one of the hardest things for care partners to do. Like you mentioned, there is generally speaking, a deep love and caring for the person who is living with dementia. And the focus becomes on them, and understandably so. The care partner sort of loses focus on themselves and making sure that they're doing okay. So I oftentimes use this oxygen airplane metaphor for people, which is basically, when you're in an airplane And if there's some kind of pressure change in an airplane, they always tell you, put your oxygen mask on first before you help somebody else, because you're not going to be any good to anybody if you're passed out in the airplane because the pressure changes. You need to be available. You need to be getting what you need in order to help somebody else. So I think that metaphor, that analogy really works well in dementia care. Is you need to be, the care partner needs to be caring for themselves and replenishing themselves in order to be the best care partner they can be for their loved one.
Another challenge that it strikes me is shared between people living with dementia and their care partner is that of social isolation and loneliness. Right? If you're working 150 hours a week doing anything, you don't have time to care for yourself, or very hard to engage in social connections. And one of the loud messages I think I heard from your article is the power of social connectedness, both in terms of resilience and in many different ways. I wonder if you can talk a little bit about loneliness. And I just reflect that in a post-pandemic world, this is probably a bigger issue than it was 4 years ago, or 4 years and 3 months ago.
Yeah, absolutely. Loneliness and social isolation was a big problem before, and it's even worse now. Is what I'm hearing from my patients, what I'm seeing in the literature is this post-pandemic time has been even more isolating and more problematic for people. But this social network cannot be, as you said, it cannot be overstated in terms of the importance for people. So that social network is important for not only providing potential instrumental care, so that practical care that care partners can lean on other people to come into the home to do things for the person living with dementia, so the care partner can go practice self-care or go do those errands that need to be done. But also the emotional support as well that social networks can provide for people. And also, social networks for not just the care partner, but for the person living with dementia as well. We know that social engagement in particular is really good for brain health. I mean, we don't think about it, but social engagement is a very cognitive activity. And so it helps give the brain a bit of a workout. So that social network is important for a lot of different reasons, and understandably a lot harder to maintain in this sort of post-pandemic world as well.
As our time starts to come to close to a close, we're not done yet, but I think we're probably going to have to start winding up. I wonder if we could pivot to something positive and talk about the joy in this. And by that, I mean, you describe, and I think we've witnessed, relationships and caregiving situations that, as challenges as they are, provide fulfillment, and the connection one has with the loved one, or sort of that social aspect. Are there things that predictive of that kind of positivity? And are there ways that we as professional caregivers for patients and their families can facilitate that?
Yeah, there are a couple of things. So one of which is basically the quality of relationship between the care partner and the person living with dementia already. So that's the quality of that relationship. The better the quality of that relationship, the more likely it is that the care partner will experience more meaning and fulfillment and joy associated with caregiving, kind of outweighing that burden. But the additional piece of that is the more resources, the more mastery they feel about their caregiving or care partnering abilities, the more confident they feel in their ability to do good by the person, their loved one, the person living with dementia, the more likely they are to find that role fulfilling and meaningful. And I think that's where neurologists and other providers can kind of come in, is helping people make sure that they have those resources, that they are connecting to places where they can learn skills for giving appropriate care so that they can feel confident in what they're doing. There's the pre-existing relationship piece that matters a lot, but I think that there's a lot of modifiability that neurologists have too, of making a positive impact on the care partner and the person living with dementia.
That's really great advice, Ange, and I definitely will refer our listeners yet again to your article, which is a compendium of useful advice about this, both in terms of the text itself and in tables that provide lists of resources, websites, books, organizations, good case examples. It's a home run, and I hope all of our listeners check it out. I'd like to wind up by talking a little bit about your work. As I understand it, You obviously are very passionate about this topic, but you have specific interest in caregiver burden and underserved and marginalized communities. And we've touched on this, but this is a huge percentage of our population. And when you look out globally, it's even bigger than that. Tell us about what you're working on, and maybe following that, what's the future look like? Where are we going to see advances in this in the coming years?
So just a really quick kind of brief history is that I've worked in dementia for almost 20 years or so now. And what I've consistently seen is when you give care partners good supports and education and resources, there are better outcomes for them and their families. The unfortunate thing is a lot of these really great interventions and things that we have are not necessarily really accessible by a lot of people, but particularly not accessible by those living in underserved communities. The last few years in particular, I really shifted into wanting to better understand that and better understand how do we provide culturally and socially appropriate interventions and education for these care partners and their families. With the current research project that I'm working on, we're looking at better understanding the needs of care partners of people who have early onset Alzheimer's disease, specifically from Black and African American individuals and other underrepresented groups. Again, the idea of this is to understand the needs before building an intervention for these groups. And I'm very excited about it. I know that there are lots of really great people who are working in this area, including Dr. Dilworth Anderson and Kalisha Bonds-Johnson, doing really fabulous work in this area. And building on what they're doing as well. In terms of what the future holds, one, I think we absolutely we have lots of really great care partner interventions out there that have been lots of research going on, but it's not really transitioning into the clinical sphere. It's really kind of staying in that research sphere. So I think it's really important that we get some implementation scientists who are taking those interventions and moving them into the clinical sphere, into the sort of like everyday, how do these actually work for people sphere. And then similar to some of this conversation we're having in terms of serving, making sure our interventions and making sure that our resources are appropriate and accessible for underserved communities, we really need to be taking a look at what these communities need rather than kind of saying this is what's available, kind of hopefully this works for you. Speaking with these communities, engaging stakeholders and understanding what are the needs in these groups so that we can provide the appropriate resources, the appropriate interventions, the appropriate supports for care partners and people living with dementia.
And I'm just thinking, imagine what this looks like with effective treatments for Alzheimer's disease, that slow progression. And, that's going to make the caregiving even more important, it seems to me. But there's an opportunity to make it a better rewarding and a better supported system as we develop these new therapies. So this is I think a clarion call for our learners listening about that they should all become dementia neurologists and neuropsychologists like you. Thank you. That was outstanding. So, Ange, I want to thank you a lot for a really engaging conversation. This fulfilled every hope I had coming into it. I was really excited to talk to you. I always love talking to neuropsychologists, but I think, again, this is really useful for neurologists, learners, people who are non-neurologists, everyone. And so thank you very much. I've learned a lot, and I really would encourage everyone to check out the article.
Well, thank you so much for having me on and giving me the opportunity to talk about this stuff that is really important to me, and I think to most of us out there. So hopefully people find the article and the resources in there useful, and thanks again for having me.
I'm sure they will. Again, today I've been interviewing Dr. Angelina Polsinelli, whose article on care partner burden and support service in dementia appears in the most recent issue of Continuum, which is on dementia. Be sure to check out Continuum audio episodes from this and other issues. And thanks to you, our listeners, for joining us today.
This is Dr. Tishme Monteith, Associate Editor of Continuum Audio. If you've enjoyed this episode, you'll love the journal, which is full of in-depth and clinically relevant information important for neurology practitioners. Use the link in the episode notes to learn more and subscribe. AAN members, you can get CME for listening to this interview by completing the evaluation at continpub.com/audiocme. Thank you for listening to Continuum Audio.